without further ado, Dr. Zach Baker and Dr. Jamie Whitlock.
All right, so we did a case study on conservative management of an acute labrum tear after a fall on an outstretched hand. Really how we're hoping this goes this morning, this afternoon is Anthony and Jared did a great job of touching on just big picture principles, phases of rehab, kind of getting into the thought process of the why and the how of what we're doing. And then we can use the rest of the time today to cover this case study and another one to put it in a specific context. Everything that we're going through today, utilize the principles from this morning to help you figure out which situations they're going to work the best in. We're going to go through phases of rehab, things that we look for from an intervention standpoint, and also from an evaluation or a testing standpoint. Appreciate them for what they are, appreciate the benefits of each test or each exercise, appreciate the limitations of them as well. So I always tell people there's really no perfect test or there is no perfect ideal exercise, but it's really what information does that test provide you and how can you utilize that information.
So for the case study that we're doing, we're going to give you guys just a general example of a patient that experienced a fall on outstretched hand. So we're saying that they are a basketball player with an acute slap tear, type 2, which we'll go into more details about the specific type of slap tear, just to kind of give you guys an overview. Saying that it just happened and it was confirmed by an MRI with no version of cuff involvement. The patient's age, 18 old, they're a basketball player, and their goal is to get back to an active lifestyle, get back to basketball, and be able to throw overhead if they need to. So a couple of different mechanisms for acute labral tear. So the one that we're talking about here is a fall where you're catching yourself on your hand. Other ones, kind of a direct hit to the shoulder or like a sudden pull of the arm can also cause acute labral tear. And then it's aggressive overhead reach, so if you're like sliding into a base, that's a sport specific example, or if like kind of you catch yourself overhead if you get that intense of a fall. Just to go briefly over some anatomy, so here we just have a picture of the shoulder joint. Involves the scapula, clavicle, humerus. The glenoid fossa, the labrum in there helps to deepen that fossa and provide stability. Kind of going over, this is a type 2 labral tear that we're going over, so that's going to involve that bicep. So 50% of the fibers of the long head of the bicep originate from the superior labrum, and then the remaining fibers originate from the superior glenoid tubercle. And then generally the anterior superior labrum has poor blood supply. And then the inferior has a little bit more. Types of slap tear, so the most common is going to be your type 2 slap tear that's going to involve that biceps. Type 1 is just slight fraying of that superior labrum. Type 2 is going to involve the biceps. There's a couple different areas it can be at in that type 2. So it can be in that posterior superior area, and that's more common in overhead athletes, and then anterior superior is more common with traumatic tear. And then type 3 and 4 are both bucket handle tears, and then it just is a matter of whether the biceps is involved or not.
So with this, just finishing up kind of the overview of the injury, things that we're curious about in regards to patient symptoms, pain, discomfort, commonly felt, a sensation of shoulder instability depending on the mechanism of as well that's present, whether it's a subluxation or a dislocation, may enhance how much of that sensation they have. Common to experience catching, grinding, popping, just something from an articular abnormality with this. Decreased range of motion, that can be passively or actively. Keep in mind in regards to that, is it something where there's actually an intra-articular lesion that's preventing them getting into certain positions, or is it something where it's just pain, weakness, instability based? And that may factor into whether you're looking into conservative or surgical management of this. Pain with overhead movement is common, and then also just in general decreased strength and stability. When we're talking about treatment options in general, the two big ones, you have conservative versus surgical. today we're going to be covering a conservative approach to it. Really the rationale, the theories, the philosophies, it would go hand in hand sequentially with what you would do post-operatively with somebody. You would just have to appreciate some of the phases you may have hard endpoints that you cannot pass just based off the protocol or the procedure that was given, but sequentially they'll still fall in the same order. Conservative management, it's been shown to be successful. I think this is really why we're all here today. Whether it's surgical or non-surgical, we're looking for ways to try to standardize this as best as we can. A lot of our surgical interventions have been shown that there's a pretty significant failure rate or lack of success with returning to our original state. And then from a conservative standpoint, there's also a high prevalence of people who have re-injuries. So what can we do collectively as a profession to have a better understanding as to what can we actually influence, how can we influence it, and then how can we actually measure it to make sure that we're influencing it in the manner that we should be or that we intend to be. When we're talking about surgical, commonly they're going to do either a debridement without a repair or a debridement with a repair, depending on the type of lesion and the involvement of other structures. That'll dictate that. But really all that that's going to give you is just a general sense as to, as you're going through the phases, how much you may or may not spend in one certain time frame.
So now we're going to get into the stages of rehab. Ann and Jared did a good job of kind of going over those 4 stages that we're going to talk in more depth with regards to this case. So the first stage is going to be that homeostasis restoration. And these are just general goals that kind of Jared already touched on. And it's going to be similar for every diagnosis. But for here, we're trying to decrease pain, get back range of motion. If there is swelling, we're trying to reduce swelling, and then trying to normalize isolate movement patterns in the shoulder. So getting into just looking at the person, what their deficits are, and trying to get them a little bit closer back to baseline with all of these different areas.
Good. And I'll touch on that. Think about this. This is the low-hanging fruit. This is the stuff you learn day 1 in PT school. So address the basics, get them back to baseline, and Jamie will touch on a little bit more detail about that.
So for treatment options, it's not just going to depend on the person. It's not like you have to do every one of these things or a few of them. You're just going to figure out what, if they have decreased range of motion, you're going to do what you can to kind of reduce symptoms and then get their motion back. So working on passively or active assistive or active motion to regain whatever motion that they're lacking. And then initially for this, if it is a fall on outstretched hand, we're going to try to, start to get them using the shoulder in ways that are not aggravating initially. So that might be carrying a little bit more initially versus going into weight bearing. So you want to just keep their aggravation low when we're in this stage, and then eventually we'll get them back into those positions where they're putting pressure through their hands and trying to get them back to being comfortable weight bearing. So just for exit criteria for this, we're just looking at mostly motion. We want to see them have that full pain-free passive motion and have full active range of motion. Not necessarily looking for them to be 100% pain-free when getting that active motion, but just making sure that they have it in all ways.
Cool. So going from there, we transition from that homeostasis restoration into the athletic foundation. To kind of summarize what Jamie said, in that first phase, regardless of what your treatment method, your intervention, your style is, it all has a common theme. We're trying to minimize pain, we're trying to minimize apprehension, we're trying to restore normal functional movement. We're probably going to do that in more of an isolated fashion. Like Jared and Ant talked about earlier, we have minimal degrees of freedom. We're just seeing, does this structure, is it sound enough to operate in isolation in the manner that it's supposed to? After we accomplish that, then we move into a little bit more advanced from a coordination standpoint, from a proprioceptive standpoint, from a general loading and movement standpoint. So with this, our goal is we want to develop control of movement patterns of the upper extremity, not only in isolation, but also through triplanar movement, through lower extremity and total body integration as well. We're also going to start introducing a little bit more loading in this phase as well. So we're going to go through loading the upper extremity in varying degrees of weight bearing. So we're going from non-weight bearing to potentially quadruped, maybe an elevated or a high plank position, and then we're going further and further more into full weight bearing. And then in general, we're also going to try to increase overall strength and stability within this phase. Slide over to the next one. As we're doing this, we're kind of covering three large subsets. We're looking at isotonic strengthening, we're looking at things that may be more stabilization oriented, and then we also want to manage just general deconditioning or mitigating the amount of deconditioning that happens with this athlete and trying to do that in a complementary role that also acts and accompanies the upper extremity. So from an isotonic strengthening standpoint, we're looking at pushing and pulling patterns. And then we can break that down into horizontal pulling and pushing and vertical pulling and pushing. We can bridge that gap through incline as well. When we get to our strength station, we'll show you different options for that along a continuum, where you may start, where you may end. Our exit criteria have certain checkpoints and tests that we can do. And when we break into the stations, they're going to be set up where we do all the testing first, so you can see what that end stage is that we're trying to get to, get familiar with the test, what we're looking for, and then we'll backtrack on the second round, and we're going to go through more intervention-based stations. So that way, you can see what our end goal is and how we may regress, progress, and lateralize along the way. From a stabilization standpoint, we also want to touch on non-weight bearing and weight bearing positions. So think about this. You can think of it from a weight bearing standpoint. You can think of it from an open or a closed chain standpoint. Part of that may have to do with the type of injury. If we have a Fuchs type injury, there's going to be some sort of sudden impact on an outstretched hand. A lot of times we could categorize that as a lack of adequate absorption. We were not able to absorb that force. The structure paid a price on it. So some of that is just